Dear audience, Assalamu alaikum. I am Professor Shamsuzzaman, Professor of Pathology. I welcome all in today's 12th lecture on Hematology. Today, day 2 of hemorrhagic disorder. And today's topic is hemophilia. Now come to first, we have to recapitulate about coagulation disorder, because hemophilia is nothing but a coagulation disorder. Coagulation disorder. What we mean about coagulation disorder? Coagulation disorder is a type of hemorrhagic disorder. A type of hemorrhagic disorder characterized by prolonged coagulation time. So it is a type of hemorrhagic disorder, that is, coagulation disorder is a type of hemorrhagic disorder characterized by prolonged coagulation time. Dear audience, you know normal coagulation time is that is clotting time is 5 to 11 minutes. If coagulation time is more than 11 minutes, we call it prolonged coagulation time. Dear audience, you know coagulation disorder is a type of hemorrhagic disorder. Now come to what is hemorrhagic disorder. Respected audience, in my day 1 lecture on hemorrhagic disorder, I have told you briefly about the hemorrhagic disorder. Today I want to just recapitulate about the hemorrhagic disorder. A group of disorder characterized by abnormal tendency to bleed due to defect in hemostatic mechanism. So due to defect in hemostatic mechanism, if there is abnormal tendency to bleed, this is called hemorrhagic disorder. Dear audience, you know for hemostasis there is a role of blood vessel, there is a role of platelet, and there is a role of coagulation factor. So for hemostasis there is role of blood vessel, that is, there is a role of blood vessel like this, then there is role of platelet, and there is role of coagulation factor. So if there is any defect in platelet, there will be hemorrhagic disorder. If defect in blood vessel, hemorrhagic disorder. If there is deficiency of coagulation factor, there will be hemorrhagic disorder. Today come to coagulation disorder due to deficiency of coagulation factor, and there are many types of coagulation disorder. Today we will discuss about the hemophilia. Before going to discuss about hemophilia, again we have to recapitulate about the classification of coagulation disorders. Now come to type or classification of coagulation disorder. Type or classification of coagulation disorder. It is classified as congenital coagulation disorder and acquired coagulation disorder. Acquired coagulation disorder. First come to congenital coagulation disorder. Congenital coagulation disorder. Coagulation disorder. Detodens, we know what is congenital disease. Disease born with is called congenital disease. So congenital coagulation disorders, number 1, hemophilia. Then von Willebrand disease, then other congenital coagulation disorders. So congenital coagulation disorders are hemophilia, von Willebrand disease, and other congenital coagulation disorders. Among the other congenital coagulation disorders, one is fibrinogen, that is factor 1 deficiency, then prothrombin deficiency, that is factor 2 deficiency, Besides this, there is factor 4 deficiency, then factor 7 deficiency, factor 10 deficiency, factor 11 deficiency, factor 12 deficiency, factor 13 deficiency. So these are the other congenital coagulation disorders. These are a bit rare. These are fibrinogen deficiency, prothrombin deficiency, factor 4, 7, 10, 11, 12 and 13 deficiency. These are the congenital coagulation disorders. Now come to acquired coagulation disorders. Acquired coagulation disorders. What are those? Vitamin K deficiency, liver disease, anticoagulant therapy, DIC, disseminated intravascular coagulation, and also massive stored blood transfusion. Massive stored blood transfusion. So these are the acquired coagulation disorder. Dear audience, you know vitamin K is needed for synthesis of prothrombin in liver. You know liver synthesizes the vitamin. With the help of vitamin K, the liver synthesizes prothrombin. If there is deficiency of vitamin K, there will be reduction of synthesis of prothrombin. As reduction of synthesis of prothrombin from the liver due to deficiency of vitamin K, there will be coagulation disorders. Now come to liver disease. Now come to liver disease. If anybody suffers from liver disease, like hepatitis, cirrhosis. If anybody suffers from hepatitis or cirrhosis, there will be insufficient synthesis of coagulation factor, because all the coagulation factors are synthesized from the liver. If due to liver disease decreased synthesis of coagulation factor, there will be acquired coagulation disorder as in liver disease. Anticoagulant therapy, respected audience, you know in many situations anticoagulant is used. As for example, it is used after cardiac surgery. If there is overdose of anticoagulant, there will be coagulation disorder. Dear audience, you know disseminated intravascular coagulation. Thrombus is formed throughout the body. This is disseminated thrombosis throughout the body. If there is disseminated thrombosis or if there is disseminated intravascular coagulation, for the formation of thrombus, collating factors, platelets, all are used. As there is used up of maximum portion of platelet and coagulation factor, there will be deficiency of platelet, deficiency of coagulation factor in the body. That will lead to hemorrhagic manifestations, and these hemorrhagic manifestations is due to consumption of platelet and consumption of coagulation factor in disseminated intravascular coagulation. So as there is consumption coagulopathy, it is nothing but acquired coagulation disorder. If in times of need, especially after road traffic accident, if there is demand of maximum blood for the patient, in that situation stored blood may be used. If stored blood is used massively, there is chance of development of coagulation disorder. There is nothing but acquired coagulation disorder. Why massive use of stored blood is associated with coagulation disorder? What happens in stored blood? In stored blood, factor 5, there is a labile factor. It is unstable factor. This factor is lost due to storing of blood for a long time. Again, in stored blood, platelet is lost. Platelet is also lost. So massive use of stored blood in times of need, it may lead to acquired coagulation disorders. Now come to hemophilia. Dear audience, hemophilia is a type of coagulation disorder. Now come to how can we define hemophilia. X-linked recessive hereditary coagulation disorder due to deficiency of factor 8 or factor 9 is called hemophilia. So hemophilia, X-linked recessive disorder. Which type of disorder? Coagulation disorder. And this disorder is due to deficiency of factor 8 or factor 9. This is hemophilia. It is X-linked recessive hereditary disorder. So it is a genetic disease. It is a genetic disease. It is a genetic disorder. In this type of disorder, male is sufferer and female is carrier usually. Male is sufferer, and female is usually carrier. That is, male suffers from hemophilia and the female usually carries the hemophilic gene, but usually they don't suffer from the hemophilia. Dear audience, so it is a genetic disorder, it is single gene disorder, and it is hereditary. It means the offspring that suffers from hemophilia, they inherit from their forefathers, from their parents. So it is X-linked recessive hereditary coagulation disorder. Dear audience, now come to pathogenesis of hemophilia. Suppose male 46 XY chromosome, as it is X-linked disorder, if this X containing red one is the mutant gene here, the male carrying mutant hemophilic gene in the X chromosome is a sufferer of hemophilia. Female 46 chromosome XX. If this X bears the hemophilic red gene, the female carries the gene, but female usually does not become a patient of hemophilia. Why? Because in case of female there is two X. One is mutant gene is one is mutant gene, and another is non-mutant healthy gene. Due to presence of non-mutant healthy gene, this mutant gene cannot be expressed. The mutant gene is not expressed. As the mutant gene is not expressed, there is no expression, so there is no hemophilia. But in case of male, there is mutant gene in the X, mutant gene, but there is no healthy another gene like that of female, that is healthy or non-mutant X. So male carrying hemophilic gene in X become sufferer. I've told you it is genetic disease. It is single gene mutation. It is single gene mutation. Single gene mutation. Dear audience, we know for synthesis of factor 8 and factor 9 there is definite gene, and that gene is present in the X. So the gene for factor 8 and factor 9 is situated in X chromosome, and this gene is associated with synthesis of factor 8 and factor 9. Mutation of this gene is point mutation, and it is nonsense point mutation. As it is nonsense point mutation, there is decreased synthesis of factor 8 and factor 9, or no synthesis of factor 8 and factor 9. If there is no synthesis, it is called a stop codon. It is called a stop codon. So due to nonsense mutation of this gene, nonsense mutation of this gene, what will happen? Either decreased factor 8 and factor 9 synthesis, or there is almost complete absence of factor 8 and factor 9. It is called stop codon, or absence of factor 8 and factor 9. Again, we recall the gene associated with the synthesis of factor 8 and factor 9. If the gene undergo mutation, what type of mutation? Nonsense point mutation. If nonsense point mutation of the gene, what will happen? Either decreased of the factor or absence of factor. If there is absence of factor, it is severe form of hemophilia. Point mutation may occur due to a structural defect of the chromosome. A structural defect of chromosome may lead to point mutation also. What is the structural defect? Dear audience, you know, if this is the short arm of chromosome, centromere, and this is long arm of the chromosome. If a segment of this chromosome is detached from here, like this, first detachment, like this. After detachment, if it is replaced here, inversely, after detachment, if it again placed inversely, what will happen? Then we get the chromosome like this. This point come here and this point come there, and it is called inversion. This structural abnormality or a structural defect or a structural abnormal chromosome is called inversion. It is called inversion. If inversion occurs, a segment of chromosome is detached, then replaced inversely. It is called inversion. Due to inversion, there may be mutation of this gene. If such type of mutation occurs due to structural abnormality of chromosome, that is due to inversion, there will be severe form of hemophilia. In this type, there will be severe form of hemophilia. So this is the pathogenesis of hemophilia. Now come to types of hemophilia. One is hemophilia A. It is called true hemophilia or it is called classical hemophilia. It is due to factor 8 deficiency. Dear audience, you know factor 8 is called anti-hemophilic factor. If there is deficiency of anti-hemophilic factor, that is deficiency of factor 8, it is called hemophilia A. It is also called true hemophilia, true or classical hemophilia. It is true or classical hemophilia. Another is hemophilia B. Hemophilia B, it is due to factor 9 deficiency. What happens here? Deficiency of factor 9, and factor 9 is called Christmas factor. So deficiency of factor 9, it is hemophilia, and it is also called Christmas disease, also called Christmas disease. So this is the classification of types of hemophilia. Now come to, if anybody suffers from hemophilia, what may be the clinical presentations? Now come the clinical presentations of hemophilia. Presentations of hemophilia. Dear audience, again we recapitulate. It is one of the coagulation disorder. So presentations may be wound bleeding. If anybody suffers from any wound, skin or etc. places, there will be bleeding, and after 5 to 11 minutes, usually bleeding is stopped. If bleeding is not stopped within this normal time, it indicates increased coagulation time. It may be a case of hemophilia wound bleeding. Spontaneous tissue bleeding. Without any injury, without any trauma, there is spontaneous tissue bleeding, indicates hemophilia. Bruise following slight injury. Usually due to slight injury, we do not have any bruise. But if anybody suffers from hemophilia, slight injury may lead to bruise. Nasal bleeding following slight laceration. Slight laceration usually does not lead any bleeding from the nose. If slight laceration leads to nasal bleeding, it may be a case of hemophilia. Bleeding from mouth following slight laceration. Bleeding from mouth following slight laceration. Then another important presentation is hemarthrosis. Dear audience, If a baby of 3 years or 2 years suffers from huge joint swelling, especially knee joint or elbow joint, following slight trauma, it may be due to hemorrhage within the joint. It is nothing but hemarthrosis is a feature of hemophilia. Dear audience, these are the presentations of hemophilia. Now come to, if anybody suffers from hemophilia, how can you diagnose hemophilia in laboratory? That is laboratory diagnosis of hemophilia. Laboratory diagnosis of hemophilia. We have to do blood examination. Thromboplastin generation test, factor 8 and factor 9 assay, and lastly identification of gene, in RFLP. So these are the laboratory investigations for diagnosis of hemophilia. First come to blood examination. First, coagulation time or clotting time. As it is a coagulation disorder, it will be prolonged. Then bleeding time, it will be normal. As it is not thrombocytopenia, so bleeding will be normal. Then we have to do hemoglobin may be reduced. That is, patient may be anemic. Then we have to do ESR. It may be within normal range or elevated, also. Then we have to do total leukocyte count. The total leukocyte count may be normal, but during the episode of bleeding, during the episode of hemorrhage, there will be leukocytosis. Dear audience, we can recapitulate. Hemorrhage is one of the cause of leukocytosis. So it may be normal count or within normal range, or may be increased. That is leukocytosis. When leukocytosis? At the time of or at the episode of hemorrhage. Then DLC, differential leukocyte count, usually normal distribution, but at the time of or during the episode of hemorrhage, there will be neutrophil predominance during episode of hemorrhage. Predominance of neutrophil when during episode of hemorrhage. So during episode of hemorrhage, predominance of neutrophil. Now come to tourniquet test. Dear audience, you know, in thrombocytopenia, in ITP, tourniquet test is positive. but tourniquet test is negative in case of hemophilia. Negative. We have to do peripheral blood film examination. First, RBC series. Cells are microcytic and hypochromic. Cells are microcytic and hypochromic. WBC series. Cells are mature. It is not a disease of RBC, not a disease of platelet, not a disease of WBC. So cells are mature with normal distribution, and normal count. But if there is episode of hemorrhage, WBC series cells show leukocytosis with predominance of neutrophil. Otherwise, cells are normal count with normal distribution. Platelet adequate in number. This is the peripheral blood film findings in case of hemophilia. Now come to prothrombin time. As it is not a disease due to prothrombin deficiency, so prothrombin time is normal. It is normal. Then TCT, thrombin clotting time. TCT, it is normal. It is also normal. Then APTT, activated partial thromboplastin time. Activated partial thromboplastin time. APTT, it is prolonged. Dear audience, normal APTT is 35 to 45 seconds. If anybody suffers from hemophilia, it is prolonged. Normal APTT is 35 to 45 seconds. Dear audience, now come to procedure of APTT. First, we have to know what do we mean by activated partial thromboplastin time. Time requires recalcified and citrated blood to clot on addition of partial thromboplastin. Partial thromboplastin is called partial thromboplastin time. So it is a time required recalcified and citrated blood to clot on addition of partial thromboplastin. Partial thromboplastin is called partial thromboplastin time. Dear audience, if this is the citrated and recalcified blood, this is citrated and recalcified blood. On addition of partial thromboplastin, here, after addition of partial thromboplastin in this citrated and recalcified blood, the time required for clot of this blood is partial thromboplastin time. When commercial activating factor like kaolin, is added here, kaolin is added to standardize the test. After addition of activating factor like kaolin to standardize the test, this partial thromboplastin time, then it's called activated partial thromboplastin time. Again we recall, time required recalcified and citrated blood to clot on addition of partial thromboplastin is called partial thromboplastin time. When kaolin as activating factor is added here to a standardized test, then this partial thromboplastin time is called activated partial thromboplastin time. Dear audience, now come to thromboplastin generation test. Thromboplastin generation test. This test is used to differentiate factor 8 deficiency from factor 9 deficiency. This test is used to differentiate factor 8 or factor 9 deficiency. So, to differentiate factor 8 deficiency and factor 9 deficiency, thromboplastin generation test is used. Now come to factor 8 and factor 9 assay. If we can assay factor 8 and factor 9, we can diagnose what type of hemophilia, whether it is hemophilia A or hemophilia B. Lastly, the test is identification of gene, identification of gene in RFLP. Respected audience, what we mean about RFLP? Respected audience, you know, we can diagnose genetic disease either by direct identification of gene or by gene tracking. What is RFLP? R restriction fragment length polymorphism. So RFLP means it is an abbreviation, stands for restriction fragment length polymorphism. Dear audience, you know, if this is gene, if this is gene within the chromosome, every individual in its gene there is a restricted fragment. And this fragment has got definitely length. Suppose this is RFL. This is very much restricted length of a fragment of gene for each and every individual, and this is restricted part of gene. It is a fragment of gene. It has got length, and this length or this restricted fragment varies from individual to individual. So this fragment is very much polymorphism. So it is called restriction, fragment, length, polymorphism. Again recall, this is a fragment of gene. This fragment has got definite length, and it is very much restricted for the individual. So it is called restriction, fragment, length, polymorphism. Within this RFLP, we can identify the mutant gene. We can identify the point mutation of the gene associated with synthesis of factor 8 and factor 9. If we can identify the gene associated with this hemophilia in the RFLP, this is the final diagnosis of hemophilia. Dear audience, this is all about the hemophilia. I have told you first the definition of hemophilia, then type of hemophilia, then pathogenesis of hemophilia, then clinical presentation, ultimately level to diagnosis. Today up to this, thanks all.